Hello, future PTAs. I hope you're doing good. Hopefully the recording started. All right, today we're going to talk about stroke. So the pathophysiology, there are two types of stroke, ischemic or hemorrhagic. Stroke is also known as a cerebrovascular accident or CVA. It occurs when the blood supply is blocked either by a clot or when a blood vessel busts and causes a bleed within the brain, either one of them damaging brain tissue because of a lack of blood flow or even too much blood flow that puts pressure on that area and damages the area. So with the ischemic stroke, there is a focal injury point. So it's one artery in the brain that's blocked. It's not diffuse where there's bleeding out into the brain like hemorrhagic. It does not progress. So whatever symptoms start, they continue until the blood clot is dissolved and the blood flow is restored. If it is caught early, then TPA can be given. That is a blood thinner within 3 to 6 hours of the stroke, of the symptom onset, and it can save lives. It can, restore blood flow and decrease the damage done to the brain. A lot of people, if they get it early enough, may fully resolve and not even show symptoms afterwards, just depending. However, you have to know what type of stroke the person is having, because if they're having an ischemic stroke, it could save their life. And if they're having a hemorrhagic stroke and TPA was given, it could kill them because it would make more bleeding into an area that's already overly, it's broken and it's profusely bleeding. So very important to diagnose what type of stroke it is. First, I know when I was living in Atlanta, there were actual stroke units. So if somebody called 911 and was suspected of having a stroke, they would send specific ambulances to them. There was only like 5 in the city, but that had, I think, a CAT scan or something in the ambulance so they could diagnose it immediately and give TPA, which was like amazing, the amount of people that it helped and the symptoms that it decreased. So that's really key. Now, the closer to symptom onset, the better. But if it is within 3 hours is best, but even up to 6, some resources say 5. After 6, it probably won't help because the damage will be irreversible at that point. So typically an ischemic stroke will happen in a time when the blood pressure is low, like when somebody's laying down, often when they're asleep, because the blood is going through a smaller artery. And so the blood pressure when you're laying down, especially when you're sleeping, goes down just a little bit. So the blood pressure isn't pushing hard enough to get that clot or the embolus, the thrombus, either one, through the artery in order to allow the blood to continue moving. High blood pressure and cholesterol are some of the initial causes of this stenosis, but at the time when the clot occurs, it's typically lower blood pressure, even though chronic high blood pressure creates the buildup around the on the walls, on the arteries, and creates more of an environment for this to happen. Okay, so embolus and thrombus, you'll hear them interchanged a lot, just kind of used as the same thing, but they're a little different. So an embolus is associated more with a cardiovascular disease. It could be solid, liquid, or gas. So even, when somebody is putting an IV in, they have to be very careful not to get gas in the line, because that gas bubble could travel to the brain and cause a embolytic ischemic stroke. It could travel to the heart or somewhere else and also cause damage. But with embolus, it is a sudden onset. Typically, they have a severe headache. Some of the cardiovascular diseases or some of the issues that it is more likely to have an embolus with are valvular disease, like mitral valve disease, acute MI, that's a heart attack, AFib, where your heart is beating really fast and the blood isn't successfully getting pumped out of the heart as well, or after a cardiac catheterization procedure. So it could happen then as well. Whereas a thrombus is more associated with atherosclerosis, where there is buildup around the walls of the artery, so it narrows the area that the blood travels through. The plaque develops. It eventually can occlude the artery, especially if some type of blood clot or embolus or anything starts to travel through that area. It could take a few days for that to build up, so it could be a little bit slower onset of symptoms. It could also be sudden, and this one is often when you are asleep or when a patient wakes up from a heart attack right after an area of lower perfusion. With a hemorrhagic stroke, this is a diffuse area of injury because a blood vessel has ruptured in the brain and it is bleeding out. So the more it bleeds out, the larger the area of injury is. Remember, not only will the area that is fed by that blood vessel be affected, but all the surrounding areas, because as the pressure increases, just like with increased intracranial pressure from anything else, it pushes on the other areas of the brain and can cause damage there as well. The patient is unstable until the bleed is controlled. So in this case, they would give some clotting agent to help stop that bleed, or possibly even do a surgical procedure to stop that bleed. If it's severe enough, or depending on what artery it affects, it could cause sudden death. Um, it could, just cause really diffuse symptoms. And it occurs when the blood pressure is high, and it's so high that it actually ruptures the vessel. So this is while the blood pressure is high, even though both are related to chronic high blood pressure. Chronic high blood pressure can build up some plaque on the arteries and cause you to be more likely to get a blood clot or an occluded artery where it's blocked off and the blood can't go through. And the high blood pressure can also make it more likely for a vessel to rupture. Here are some of the risk factors for stroke. So some of the primary are high blood pressure, heart disease, diabetes, smoking cigarettes, because remember that constricts the blood vessels, or TIAs. Those are what we usually call mini strokes, where they have stroke symptoms that resolve. Secondary are obesity, high cholesterol, certain behaviors that lead to high blood pressure, like excessive salt intake or high stress environments, physical inactivity, and increased alcohol consumption. All of those can lead to a more likely risk of strokes. And one that was not in score builders, but I've heard my whole life and I have always believed to be, I've heard it from doctors, is birth control. Certain birth controls can also increase your risk of stroke, specifically if you have symptoms while you're on it, like migraine with an aura. If you're on birth control and you're having a migraine with an aura with that visual disturbance, then you're at a significantly higher risk for having a stroke. So that's one that didn't make the book, but makes reality. TIAs, will go into them a little bit more, typically caused by a blood clot that temporarily blocks the artery, but that is then resolved, it's dissolved, it can break away or get into smaller pieces so that it can move freely through the artery, and the blood flow is restored before any lasting damage or effects occur. So typically the symptoms are similar to a stroke symptom, but they resolve within 24 to 48 hours. The arteries that are the most often affected are the carotid arteries or the vertebrobasilar arteries. And if you have many strokes or TIAs, then you are at a lot greater risk of having an actual stroke. Here is the presentation. So it's different whether the stroke occurs on the left side of the body or the right. And I want you to know this really well, okay? Because remember the different sides of the brain. have different functions. So the left hemisphere stroke, it causes right-sided hemiparesis, weakness along the right side of the face and body, but it also can increase frustration in the patient, cause decreased processing, aphasia, which is speech problems, dysphagia, which is problems swallowing, motor apraxia, so difficulty with coordinating movements, decreased discrimination between sides, so difficulty figuring out right side from left, or right hemianopsia. So hemianopsia is where half of the visual field is cut. So if it was on the right side, this is my right, I don't think it's your right, but then half of each eye would be, it's hard to do, would be blank. You wouldn't be able to see out of that. Whereas with a right hemisphere stroke, it can cause you to have decreased focus or attention, poor judgment, memory issues, left neglect or lower attention to the left side of the body, impulsivity, so difficulty regulating their behaviors, decreased abstract thinking, so harder to think outside of the box or to imagine things, mood swings, which they call emotional lability, 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 or left hemianopsia, so still a visual field cut on one side where you're not able to see that portion. So impact of stroke based on the artery affected. So the first three, we're going to go over. I noticed that they're not in score builders anymore, and so I don't know that you need to know them as in depth as what I used to require. But the anterior cerebral artery is the yellow area in the middle. That's the part of the brain that is affected if the anterior cerebral artery is blocked, occluded, ruptured, whatnot. So it typically affects the medial frontal parietal lobes, basal ganglia. I'll let you read what areas it affects. But some of the signs are weakness and sensory loss on the opposite side of the body, that's contralateral, but mainly in the legs, so not as much in the arms. It can cause urinary incontinence, apraxia with especially with initiating movements and using both hands for a task that's bimanual. Abulia, which is your low willpower, slowness, delay. Contralateral grasp reflex, where anything that touches the palm surface in the hand, they will grasp again as if infants do. That infantile reflex returns. However, if the circle of Willis, so that pink area in that bottom figure, if it's intact, even if the anterior cerebral artery is blocked, then sometimes the blood flow can travel around that area from another artery and still perfuse that brain tissue. So it may not cause symptoms at all if the circle of Willis is intact. With the posterior cerebral artery, I'll let you read the areas that it affects. Some of the symptoms are hemianesthesias, so sensory loss on the opposite side of the body. Central thalamic pain. So thalamic pain is like a hypersensitivity, a burning, tingling sensation, pain in responses to changes in temperature or emotional stress, and it's due to the central translation of nerve input being damaged. So the brain cannot interpret the input accurately, basically interprets all the input coming in as painful. Okay, so every input, whether it's temperature or light touch or anything, any stimulus, any sensation coming in, your brain looks at as pain, and so everything is painful. Hemianopsia. Homonymous, okay, that's much better. Homonymous hemianopsia, so that is a visual field cut on the opposite side. Then we have visual agnosia, which is the inability to recognize objects. And then prosopagnosia, which is the inability to recognize faces. If they have both of these, they may have what we call cortical blindness, where the eyes are not damaged, but the area of the brain, so the occipital lobe, that translates all that input into meaningful information is damaged, and so we can't interpret any of the input coming from our eyes. So it's as if you are blind, because even though you can see, you cannot comprehend any of the input that you're receiving. So it could cause that amnesia or memory problems as well. Usually, if the occlusion is proximal to the posterior communicating artery, then the effects are minimal, because the blood supply from other areas can kind of take over and still perfuse and provide the oxygen needed to keep that area alive. With the middle cerebral artery, this is the most common type of stroke. So usually when we say left-sided this or right-sided this, it was the middle cerebral artery that was affected, and it affected the whole left side of the brain or the whole right side of the brain. So it is the red area in that picture I didn't mention before. The blue area is the posterior. It's blue, and all of these are kind of different angles, but middle cerebral is that red area in the picture, and it causes diffuse damage. It can lead to increased intracranial pressure, loss of consciousness, brain herniation. It could even cause death, just depending on the severity of the bleed or the amount of time that that artery is blocked. So this is kind of your typical, what you think of as stroke symptoms. You have contralateral spastic hemiparesis and sensory loss to the face, arms, and legs. So weakness, loss of sensation, the whole opposite side of the body as the stroke happened. So if it was a right-sided stroke, the whole left side of the body would be weak and have abnormal sensation, may even have some spasticity. Aphasia, especially if it's on the left, because we think left language. So a lot of our language is developed and interpreted on the left side of the brain. You may have neglect of the opposite side of the body. Anosognosia, which is the inability to recognize your own deficits or conditions. So they may be completely unaware. I had a patient before that was completely unaware of her left arm. It was flaccid, so it was just hanging at her side. And she would sit on it and lay on it, and like, if you weren't careful, get it tangled in like a wheelchair wheel. I mean, like, it just did whatever. She didn't pay any attention to it, no awareness at all that it was there really, or that there was an issue with it. Apraxia and spatial deficits, especially if the stroke was on the right side of the brain. And then that homonymous hemianopsia. So you may still have those visual field cuts where it's difficulty to see out of different parts of your eye. And it's not the vision that's the issue, it's the interpretation by the brain that is the issue. All right. All right, so these next, not this one yet, the next one. Okay, basilar artery stroke can cause ataxia, vertigo, dizziness, and bilateral deficits with like coordination, walking. Could even cause some issues with speaking and swallowing, based on their presentation. Brainstem. This one is in Score Builder still, so not sure if they're just wanting you to know it a little bit better, but brainstem stroke will cause the vitals to be unstable, could cause a decrease in the consciousness, difficulty swallowing, could cause weakness or paralysis on both sides of the body. With the cerebellum, this one is also in Score Builder, so definitely know these two well. It can cause dizziness, headaches, nausea, vomiting, ataxia, decreased coordination, double vision, tremors, language problems. One of the ways that some people will remember the signs of cerebellar damage is vanished. So the acronym VANISH for vertigo, ataxia, nystagmus, intentional tremor, slurred speech, hypotonia, exaggerated broad-based gait, and dysdiadochokinesia, which is spelled wrong. It's supposed to be with a Y, but that was what the picture showed. Dysdiadochokinesia is the inability to perform rapid alternating movements. Another one that's common is nystagmus. Oh, it's there. It's not on the left side, but it's in the picture. All right, spinal tracts, just kind of to be aware of where they are, what they do. So the corticospinal does fine motor control limbs. The vestibulospinal allows you to make postural adjustments related to head movements and acceleration, like when you're riding in a car or stopping. Tactospinal tract, it gives you visual information, spatial awareness, muscles of the neck and head are also in that tract. And then the rubrospinal communicates with the thalamus and the cerebellum for coordination of movement. Okay, this is kind of a side note. You don't have to exactly memorize this, but it's kind of to know and to revisit in the future. Locked in syndrome, this is when someone has a stroke of the vertebrobasilar artery. It will cause paralysis of all muscles except those controlling eye movements, but the person is aware. So they're unable to speak, they're unable to move. Their life-sustaining activities like breathing, heart rate, all their vitals are sustained. So they're intact, they're normal. So they can live a long time, but and the cognitive is still there too. They can hear, they can see, they can understand, but they cannot move. So really, really hard situation there with locked in syndrome. Vestibulobasilar artery is affected. So these are some of the assessment techniques that you might want to look into because PTs will be using them in their eval to determine their stroke patients' deficits and to show progress. So knowing how to read the scores of these would be beneficial to be able to read that PT eval. This is just kind of a roadmap on what we're going to go over as far as techniques. Before we discuss that, though, let's talk about plasticity really quick. So treatment gains are achieved by neuroplasticity, the ability for the brain to repair itself, to organize or reorganize neural pathways in order to allow a portion that would normally, let's say the area that controls the left arm is damaged. That would be over here though. It can rewire the brain and actually cause a different area of the brain to now receive and send information to that arm. And so that's what happens when the brain rewires, is new pathways develop. Practicing activities repetitively for a certain duration increases the number of synapses in the neurons, so it fires more as well. So not only can it rewire and rework the system, but it can also cause it to fire more and be more aware of a body part or useful to that body part. Plasticity in the muscles is what allows us to get stronger and larger and more efficient, but in the brain, it allows regeneration of the like healing of the brain to be used again. All right, PNF we've talked about pretty extensively already. So we're using proprioception or sensory input to stimulate a motor response. That's really the breakdown of it. So remember, afferent activation is that sensory input, efferent is the output, and so you're kind of connecting that loop to allow for more functional movements. Of course, we've talked about all this with the importance of your body position and manual contacts, verbal cues, all that. It's integrated. It's a positive coach that your approach. You're trying to get the most functional movement, mobility out of the patient as possible. Some of the principles, we really haven't talked in depth about like what is going on. So there's a thing called after discharge. So it's a lasting effect of a stimulus after the stimulus is moved. So your hand placement is really important because even when you remove it, there is a certain amount of time that they still get some input, some lasting effects from that stimulus. Temporal summation, so multiple small stimuli in short duration produces a larger effect. So a whole bunch of small ones go together and produce a larger effect. Spatial summation, multiple stimuli in various locations combine to form a greater response. So even stimulus in different locations can all come together and form a bigger response. Irradiation, we've talked about, that's the overflow of energy from stronger muscles to weaker muscles to allow for a stronger contraction. Successive induction, once the agonist muscle has fully fired, the antagonist muscle kicks in. Remember, there's that relationship where one should fire and the other relax. And then once it's done firing, it starts to relax because it can't fire anymore, and the other one begins to fire. So in a normally working system, then you can use firing of one to inhibit the other, and then switch and firing of the other to inhibit the first. So reciprocal inhibition, while the agonist is active, the antagonist is inhibited. So while one muscle group is firing, the other cannot fire, unless you have cerebral palsy or something where you have muscle co-contraction. But it shouldn't happen. There is a PNF video I have attached here if you want to watch it and learn a little bit more about some of these concepts and how it works. This is just going over those patterns that we've talked about: D1 flexion, D1 extension, D2 flexion, D2 extension, trying to go towards the seatbelt, and then the scapular patterns as well. With the leg, once again, the flexion, extension, and the pelvis patterns. One thing I didn't mention in the PNF lecture was that anterior elevation of the pelvis and posterior depression are what you normally use when you're walking. That's your normal pelvic patterns when you are walking. And so oftentimes we use those to kind of mimic walking, but the others we don't use often. Benefits of PNF could help patients relax more. It could increase their ability to initiate movements, increase their coordination, their strength, decrease their stiffness or their spasticity, decrease their fatigue, and it can decrease their pain. Some of the techniques that facilitate a muscle contraction, so they're trying to wake the muscle up and allow it to contract more, are approximation. Remember, that's like pushing the joint together. Joint compression, about the same. Ice can do it some. Light touch, quick stretch, resistance, tapping. That's really one of the main ones you use in PNF, tapping over the muscle you want to activate, and traction, doing a quick pull and then letting go, and it releases back more towards the contraction. Inhibition, deep pressure is inhibiting. That's why those hand hugs are important. A prolonged stretch is inhibiting. Warmth is inhibiting, and cold after a long time can also be inhibiting. So if you're wanting the cold to be facilitating, then it needs to be a short amount of cold, like that cold spray or something. If you want it to be inhibiting, then a longer amount of cold, like an ice pack on the area for a while, would be more beneficial. All right, neurodevelopmental treatment. We talked about this in class just a little bit, but the main thing I want you to know is that we are attempting to use normal task with hand placement on the patient in specific points of contact, key points of control, really, like on the pelvis or the proximal muscles, in order to develop skill, improve functional movement. So you manually assist a patient through different functional movements. You put your hand places on those key points of control to increase certain muscle activation. You're focusing on relearning movement patterns, using both sides of the body together, and decreasing compensation, so they're not using the wrong muscle groups. Through any type of functional activity. So some of the common ones are weight-bearing activities, trunk positioning, rotation is a really good thing to bring in to NDT, stability training, functional tasks, blocking the compensation. So all of these are ways to use NDT. There are NDT trainings that are very specific and specialized, but an overview is that. When someone is healing from a stroke, they have a typical pattern of healing. It's called the Brunstrom stage of motor recovery. where the first stage it's flaccid, so it's just kind of hanging down at the side. Then it starts to develop some spasticity. The spasticity gets worse before it gets better, which is key. You will have a test question on that. If the spasticity is getting worse, it doesn't mean the patient's getting worse. It actually could mean they're going through the normal healing process, because it does get worse before it gets better. Then they get to where at level 4, they're able to break through that spastic pattern some to do a little bit of um, uh, intentional movement. 5, they're able to do some movements that are isolated away from the synergy pattern altogether. By level 6, the spasticity is gone, and they are able to do movements almost near normal. So maybe not normal speed or coordination, but otherwise they're able to reach out and fully grab the cup and bring it to their mouth. And then 7 is when once they are back to a normal movement pattern with normal speed and coordination. All right, synergy patterns. These are typical movements that are seen together when someone has spasticity. So in the arm, there is an extension and a flexion synergy pattern, with flexion typically dominating more. So the extension, you have shoulder depression, protraction, adduction, internal rotation, elbow flexion, forearm pronation, wrist extension, finger flexion. There we go. Oh, you can't even see half my arm. That's the extension one. Okay. Flexion is the shoulders elevated and retracted, abducted to 90 degrees, externally rotated. Elbow is flexed, forearm is supinated, wrist is flexed, and fingers are flexed. So that position. Okay. The typical hemiplegic arm is kind of a combination of those, more flexion than extension, where the shoulder is adducted, the elbow is flexed, forearm is pronated, and wrist is flexed. So in that position. All right. So the one I want you to know the best on there is the hemiplegic arm, but also know the that upper extremity flexion dominates and what that includes. With the lower extremity, extension dominates. So the extension, you have hip extension, adduction, internal rotation, knee extension, ankle plantar flexion, and inversion. With the lower extremity flexion synergy pattern, you have hip flexion, abduction, external rotation, knee flexion to 90 degrees, ankle dorsiflexion, and eversion. With the hemiplegic leg, typically the hip has slight flexion and adduction, like that scissoring gait. The knee is extended, the ankle is plantar flex. So like the person in the picture there, where the knee stays kind of extended and the ankle plantar flex, and then they have a scissoring gait pattern because of that adduction. Swiss ball training. So you can use an unstable surface to increase core activation, to challenge the core stabilizers, to increase sitting balance. You can do whatever treatments you want to on it, and prone and sitting and moving and marching, eyes open, eyes closed. We've went over some of those in lab, and we'll go over some more, but just to have it all kind of in one place, there's your Swiss ball training or TheraBall. Some other treatment activities, looking towards the affected side of the body. The more input you get from that side, whether it's sensory input, visual input, even hearing from that side, the more the brain will connect to that side again. You do not want them to continue to neglect that side if you can help it. Even looking in the mirror sometimes can help in drawing their attention towards that side. Strengthening of the weak side, gait training, all good treatments. Constraint-induced movement therapy is a very specific treatment. We talked about it with cerebral palsy. It was created initially and tested initially in stroke patients, and so they constrain the uninvolved limb, could be by a mitt, could be by a sling, to force the patient not to use their stronger side and to use the weaker side. And then they have them do very specific tasks. True constraint-induced movement therapy was originally done for 6 to 8 hours a day for 2 to 3 weeks, with the constraint worn 90% of their waking hours. So it was very intensive, not something that your insurance company would typically pay for. And so they've got 1,000 modified versions of it to account for one that's, more realistic. Home exercise program would be very key if you were seeing a patient like this in an outpatient setting, though, because they do need daily practice for an extended amount of time in order to rewire the brain. So what it does is it kind of forces your brain to think, I have to use this side, and to pay more attention to it and to develop those new pathways better. Daily activities can become treatment: pouring, carrying, wiping, reaching. And while you're progressing, you can focus on speed of the movement, coordination of the movement, doing two things at once, which makes it more difficult. It helps with range of motion, strength, dexterity. I think the more functional you can be with neurological patients, especially if they have any cognitive deficit, the better, because when they see, oh, I'm doing this motion over and over because I'm wiping a mirror and I want this mirror to be clean, then it makes a lot more sense and they're a lot more motivated to do it than if you're just like, move your hand left and right and left and right, and then they're just bored and not seeing any real connection to something that they are motivated to do. So the more functional, the more likely they are to do those movements at home and to progress. Other functional, we already talked about this. It increases compliance. The patient understands it better. They're more likely to practice it. Walking while holding something is really hard, especially if it's like a cup with water in it. A lot of people struggle with that once they have any balance issues. Walking while you're talking is really hard. Walking with head turns is really hard. So, I mean, there are many ways that we can add difficulty to just the normal everyday task in order to progress them, or that we can simplify it a little bit so that they can become more and more independent with those tasks. All right, some of the definitions. I want you to read these. I'll go over them really quickly, but read them on your own so you kind of can be there and know what people are talking about when they're talking about things. So infarction is an area of tissue that dies because it doesn't have enough oxygen. Lack of blood flow is stopped blood flow is what's causing that. Hemiplegia is paralysis on one side. Spasticity is a velocity-dependent resistance in passive stretch. Tone is resistance to passive stretch. It's due to viscoelastic or reflexive mechanisms, so it's not velocity dependent. Flaccidity is the absence of muscle tone. Lesion is abnormal brain tissue due to injury. The penumbra is the area around the ischemic cord. And the thing that's really important, so there's an area that's dead, that's the ischemic core. The area around it, the yellow in that picture, is the penumbra, and it is where neuroplasticity takes place. So that is where the most healing and rewiring and firing occurs when we're doing therapy, is in that penumbra. So know that word for sure. Apraxia, motor disorder, making it difficult to produce purposeful movement and speech. Agraphia is a disorder of written language. Clonus is that quick beating movement. It's typically, if you dorsiflex the ankle, you'll see it in their foot, a quick beating more than 3 beats. And it's a sign of an upper motor neuron lesion or damage to the brain or spinal cord. Somatognosia is the inability to recognize one's own parts. Anosognosia is when you don't understand your deficits, unaware of the deficits. And then TIA, we already talked about, the mini stroke. Aphasia, so we've got 3 more slides. Hang with me. I know it's a long lecture, but it is an acquired language disorder related to the inability to name objects or find words because of brain damage. I do want you to know Broca's aphasia and Wernicke's aphasia. You will see it on test, my test, the board's exam. You will see those words. You need to know what they are. So Broca's aphasia is when you're unable to put the words together to make fluent statements. So they also call it non-fluent aphasia. So it's a difficulty producing speech, talking, broken speech. Wernicke's aphasia is low comprehension of written and spoken language. So they call it fluent aphasia because you can say the words, but you don't understand what's being delivered to you. You don't understand speech. So Wernicke's is difficulty comprehending somebody else's speech, even in written language. And Broca's is inability to produce speech. Global aphasia is both, when they have difficulty understanding and producing speech. Okay, so Broca's broken speech, difficulty speaking, producing speech. Wernicke's is low comprehension, difficulty with written, and I say written because the W's is what I remember it by. Wernicke's and written and spoken language, difficulty comprehending that. And then global is both. Two more syndromes. Pusher syndrome is a disorder after a stroke where a patient pushes toward their weak side, away from the hemisphere affected. That's really, so hemisphere, yeah, away from the hemisphere affected. So basically their strong side is like, whoa, something's wrong here. And so it extends, it gets that extensor tone that ends up pushing them towards their weak side. The extension is one of those protective mechanisms that when our brain is like, oh, you're about to fall or you have some damage, then sometimes we go into that extension. And so that extension is a protective mechanism of trying to just pull in all the muscles it has in order to, um, support the body and protect it. But then it ends up pushing towards the weaker side and causing a lot of balance problems, postural problems, difficulty standing, sitting. The patient is not aware of it. They really have trouble locating midline. So one of the best things to do when you're treating a patient like this is to put a mirror in front of them with a piece of tape or something right down the middle and have them try to sit upright, because they're pushing to one side and you want them to try and sit where their face is lined up with the middle of that mirror, so they can start to reorient to what is upright again, because it doesn't feel like it's upright to them. Typically, Pusher syndrome will resolve within 6 months on its own, and with treatment, it could resolve more quickly. Wallenberg syndrome, this is where a stroke occurs in the lateral nuclei and it creates a vestibular storm. So they push towards their involved side, their stronger side. So if the lesion is over here, they're now pushing towards their stronger side. They have vertigo, so dizziness, balance issues, visual deficits. The eyes will roll towards the affected side, which will cause a lot of vision problems. They may have double vision. They may have slurred speech. A lot of balance issues and coordination issues with Wallenberg syndrome. All right, that is it for our stroke lecture. If you have questions, let me know, and I will see you on the next one.